One. Okay, so start.
Uh, Good evening, everybody. Today we are having a live session on examination of varicose vein. It is very important, relevant for undergraduate and postgraduates. For this live session, we have got with us Professor Robinson George, Chief Department General Surgery and Laparoscopic Surgery, uh, Pushpagiri Medical College, Tiruvalla. Heartily welcome you, Professor Dr. Robinson.
Thank you, sir.
Very kind of you joining and taking your time with us. And we have got Ms. Neelanjana R, who is presenting the examination of varicose vein in detail, which will have interactive discussion with her. She is from the same college, Pushpagiri Medical College. She's final year student. Welcome you, Neelanjana.
Thank you.
And last week we had a successful discussion about peripheral arterial disease, wherein Professor G.V. Manoharan sir from Manapula Vinayagar Medical College, Puducherry, he has joined and had a very good discussion. And his two students, Samir Nanda and Harirana, presented very well and had a good interactive discussion. Sir said he will join little later. When he joins, beforehand only I welcome him also. He's quite senior faculty in our system. I welcome all students who have joined and which be there in this platform. Without any delay, welcome everybody who will join this platform. And to start the discussion, we'll go through the Neelanjana, start her presentation. We'll have a discussion. Once she presents her history, we'll have a discussion. Then again, when she presents the examination, again we'll have discussion. We'll have interactive discussion about varicose vein management. Neelanjana, start your presentation.
Yes, sir. Good evening. Case presentation of varicose vein. Next slide, please. So, presenting a case of Mr. Das K, who is 60 years old male, who is working as a security guard, hailing from Tiruvalla, belonging to middle class according to modified Kupaswamy scale. The date of admission is 1st of October 2024 and date of examination is 2nd of October 2024. Next slide. Chief complaints: dilated veins over the left lower limb for 2 years, wound over the inner aspect of ankle of left lower limb since 6 months. Next slide. History of presenting illness: the patient was asymptomatic 2 years back. Later, he noticed dilatation of veins over the left lower limb. The dilatation was initially noticed in the leg and over a period of 2 years gradually progressed to thigh. The dilatation increases in size on prolonged standing and walking and decreases on lying down with the legs elevated. He also gives a history of generalized swelling of the left lower limb more towards the evening, which gets relieved on taking rest. The patient also complains of night cramps, which is associated with itching of limb more towards the night time. Next slide. 6 months ago, he developed a wound over the inner aspect of the ankle of left lower limb, which followed itching. Initially, the wound was approximately 2 finger breadth vertically, but progressed over a period of 6 months to the current size of approximately 3 finger breadth, associated with pain. There is no history of discharge from the ulcer, no history of altered sensation in the skin surrounding the ulcer. Next slide. Negative history: no history of fever, no history of trauma to the leg, no history of abdominal pain, distension and chronic constipation, no history of chronic cough, no history of prolonged immobilization of the lower limbs, no history of prolonged hospitalization, no history of breathlessness, cough and hemoptysis, no history of previous surgeries for varicose veins. Next. Past history: there is no history of diabetes mellitus, hypertension, asthma and tuberculosis. No surgical history in the past. Next slide. Personal history: the patient consumes a mixed diet. He has normal appetite, adequate sleep. The bowel and bladder habits are regular. There is a history of smoking for the past 20 years. No history of alcohol consumption. Next slide. Family history: his mother has a history of varicose veins. Next slide, please. Coming to the summary, a 60-year-old gentleman who is a security guard by occupation presented with complaints of dilated veins over the left lower limb For the past 2 years, insidious in onset and gradually progressive in nature, increased in size on prolonged standing and relieved on taking rest with elevation of leg, associated with night cramps and itching. He developed a wound over the medial aspect of the left ankle, initially small in size and later progressed to the current size of 3 finger breadth vertically. From history, probably a case of varicose vein involving the great venous system.
We'll discuss about little bit about the history, Robin.
Yes,
We'll
sir.
go back to the history of present illness. Shreya, go back to the slide. Still back, still back, still back. Yeah, one more back. Right. You have told discharge. Why, if there's a discharge, what it means for you?
Sir, usually ulcers consist of some discharge like serous discharge, serosanguinous or purulent discharge can be there from ulcers. So if it's a serous discharge means it's actually a healing ulcer. Purulent ulcer discharge can be from infected ulcers which are actually not healing ulcers. And serosanguinous discharge occurs in malignant ulcers commonly, sir.
You said pain. What is the cause for pain in such a patient?
Sir, the pain is defined by many factors. One of the factors is chronic venous hypertension. This is because in a venous disease like varicose vein, due to prolonged standing, there occurs pooling of blood in the lower limb. So, due to this pooling of blood, there occurs chronic venous hypertension, which can cause pain in the patient. Also, irritability to the nerves, which are supplying the veins, can also cause pain.
Perfect.
Like
Why
this.
altered sensation history? You asked.
Sir, it's in relation to the ulcer. If there is a history of altered sensation, then diabetic ulcers and in ulcers associated with peripheral vascular occlusive disorders, the patient can have an altered sensation.
Share next slide. Fever. Why fever?
Sir, to rule out deep vein thrombosis.
Okay. Breathlessness and cough and hemoptysis.
Sir, it's actually a complication of deep vein thrombosis like pulmonary embolism. So, in order to rule out that, I have history of breathlessness and
Trauma.
embolism.
Why trauma history?
So trauma to the leg can cause injury to the veins. Also, trauma is a risk factor for deep vein thrombosis.
Next slide. Fair. You said no surgical history in the past. What exactly you meant to that?
Sir, if there is a past surgical history of varicose veins, and it means that this time it's a recurrence of the vein itself. So I have asked to rule out that, sir.
So he has undergone any surgery for varicose vein earlier?
No, sir.
No surgery in the abdomen or anything?
No, sir. No surgical history.
Fair. Next slide. Okay, next slide. You can little more detail. Your chart is absolute perfect, but you can explain this chart because how many siblings. The chart says that I'm not questioning you. It's perfect, but tell how many siblings, how many children patient is having, and how many parents, how many siblings they are, and it may give a economic backup also, social backup also, and valid. You already told mother has a history of varicose vein. So whether how many sisters or siblings to the mother, whether they are having the varicose vein, may be significant, even though commonly it is secondary, could be a primary varicose vein where it runs in the family. Familial varicose veins are known talk, present usually in the younger age group. Okay, otherwise it is perfect. I am not questioning your this slide, but explain little more detail because even though you put the chart, you can always explain it in a clear way. Okay, next
Yes.
one. Shreya, next slide. But you said the wound, somewhere I saw wound. Why you have put a wound? You can direct. Why you are not put directly? You can put as an ulcer, no? Somewhere I saw here there is a wound. What is? How will you define a wound? What is the definition of wound? Is it same as ulcer or there is a
No,
difference?
sir. Ulcer is a break in the continuity of the epithelium, sir.
Okay, make in the continuity of the epithelium because of the cell death, molecular death, whatever you call it. Wound.
Yes.
What is the wound?
Uh,
What is
uh,
the difference between the wound and ulcer? Wound is defined as disruption of tissue or organ structurally and or functionally. So anything, liver, organ, chest wall, skin, soft tissue, anything is wound. Whereas ulcer is a type of wound. Ulcer is only lining. It's epithelium. Whereas wound is a very gross terminology which covers so many things. There are so many classifications for the wound. So you use very specific ulcer. You can very well tell ulcer. Even the patient may say in his own word, we can always convert into a clinical terminology
Oh,
and put it
yes.
into the ulcer. So that unnecessary, what is wound, what is the difference between the ulcer, of course you need to know. But that conflict will not arise when you present. Okay, wound is a
Yes.
disruption of tissue structurally and or functionally. That's the definition. It's a very gross terminology, whereas ulcer is a very specific one. It's a epithelium lining. It is only in the lining also. When a lining disruption occurs, that is called as ulcer. Okay, right. So
Yes.
over to Robin. Now we can take over and about history. You can ask her a few questions and highlight about these things or anything or anything.
Yes, yes, sir. Thank you. Nilanjan, a good presentation. Sir, can we go to the first slide? Chief complaints of your patient are swelling in the lower limb, and you have a wound like sir said, an ulcer also. Yes.
Yes.
Okay. So you have covered all the classic just for revision of other students who are taking part in this, probably second years also. You cover all the basics of Socrates, a site, which is the left lower limb. Onset. Can you go to the next slide, Shreya? Yeah, the onset, which she has explained, that is 2 years back, then noticed over a period of 2 years, gradually progressed to the thigh, and also the extent of the limb. It started from the leg and it has gone to the thigh.
Yes.
Yes. So the
Yes.
onset is also clear. Character of the problem, that is a swelling, that is extent, you have explained also. Relieving and aggravating factors, yes, very good. Uh, why generalized swelling? That is the next complaint that you have said, associated symptom.
Yes, sir. The patient gives a history generalized swelling that may be probably due to the chronic venous hypertension, which can cause a stretching of the fascia covering the veins, and this can cause transudation of fluids, and this transudate is causing an edema in the legs, sir.
Yes, very good. So also remember that there's something called a mixed disease when it
Okay.
comes to vascular system. You have arteries, veins, and lymphatics.
Okay, sir.
Okay, so you're right. You're absolutely right. You have gone up to PG level. That's very good. I don't even expect my PGs to answer this question. You have done it very well. So that's fine. Your explanation is very good. Next, to Chori Chodyam, what we say. Why did you say night cramps? And you have to explain something more, because this is very like you're undergraduate. You're not a postgraduate. For PG level, we will accept night cramps. We'll ask a question. You have to say this night cramp site. Where was it? What onset? Okay, we know, but is it when the patient is sleeping, suddenly wake up from sleep? This is what we see at home, no? Our
Yes.
mothers will say that suddenly they go to with severe pain. The character of the pain is very important here.
Yes.
Alle? Ah,
Yes.
yeah. So, what is the reason for this night cramps?
Sir, this is because of venous cooling, as far as I know, there can occur an alteration in the microcirculation, hyper viscosity, and platelet aggregation.
No, that is too much. You're giving too much of it. No, it's a,
And
the answer
also,
is
Why it is in the night? Why
ah,
they feel in the night?
sir,
Why
that
and
is
why is not for the day cramp?
sir has given clue.
Why they feel more in the during night time?
The answer is in physiology. What is the difference between artery and vein? That is first clue I can. Nothing more.
um,
What are veins also known as? The answer to this is there in one book called S. Thus that we used to read before.
sir, I'm not.
Veins are also known as capacitance vessels.
Yeah,
Alle, sir
yes,
already parju. Daytime, you don't. These patients don't complain. They are moving.
yes,
There is no question of stasis. But in the night time, what happens when the patient is standing for a long time? There is pooling. But then why the cramps happen when the patient goes to bed? Again, the answer is in something to do with anatomy.
the
Where does the
calf
blood
muscle
flow?
pump is the calf muscle pump is inactive at the
It
night
is,
also.
yes, it is inactive at night. We agree. But then suddenly, why cramps? Then it means it's active, no? How does it become active? We are sleeping. We are not doing karate at night.
What exactly happens when there's a this nighttime capacitance vessels? There will be stasis, cooling, no? Diaphragm blood is stays there is stretching also. You can add on to the answer, Robin.
Yeah, you know what is the thing in anatomy? The blood flows from superficial system,
To deep.
no, via the perforators.
Yes.
The deep system and the perforators, as you know, superficial is just below the skin. Perforators are within the deep fascia, and the deep system is within the muscle, which you have said.
Yes.
They are calf muscle pumps. They are small hearts which
Yes.
work to do this. At night, these pumps are not supposed to work, but unfortunately, daytime, these vessels are like this. They are capacity, full capacity. The minute they go to bed, don't you think these guys should collapse?
Yes.
Normally, what do veins look like normally and when they are stretched? Ellipse. It is like this.
Okay.
These guys, the blood has to go back. They are
Yes.
within deep system. Now, unfortunately, the muscle will start moving. Cramps. Simple. Simple anatomy and physiology. Nothing more. No other things are very high five. Keep it always simple and it's all easy. Surgery is simple. It's this patient also is so complains of itching
Yes, sir.
more towards the night time. Can you please give us the reasons for itching in this particular case?
Sir,
The
in this
pruritus.
particular case, the due to again due to pooling of blood or stasis of blood, there occurs chronic venous hypertension, and the microcirculation gets altered. So the RBCs get trapped there, and there occurs a lysis of RBCs, which releases hemosiderin, and this hemosiderin is causing itching in this patient.
No, hemosiderin does not cause itching. That's why we asked that question. That does not cause the itching.
Exactly.
If you have read the theory and SRB sir's new edition, latest edition, he has explained very clearly every step. What are the cells? There are two pathogenesis for ulcer formation. You have already
Yes.
told us there is ulcer also.
Yes.
There are two hypotheses, pathogenesis.
White cell
One you have said is the white cell
yeah.
leukocyte trapping. Now, it is not leukocyte, it is lymphocytes, yes. And
Yeah.
there are three cells also of that one causes this problem. That is very naughty.
Which cell?
Which is that? It is there. Pakka clearly it is given. It is like Bible. For me, SRB sir's book is Bible only. I have read it and passed. All of us have passed, VG. There are the two. It's very easy to remember also. One, you have said yes, hemosiderin lysis, but hemosiderin causes some problem. The discoloration is because of hemosiderin, but the itching is pruritus is not because of what causes itching otherwise in your body. What is that cell?
So the
What?
macrophages.
Macrophages? No, something with M only.
MOLA, mast cells.
Mast cell.
Mast cells are activated.
Histamine.
Degranulation. These guys come out. Histamine.
Yes.
Scratchy. Simple. Shreya, can we go to the next one? Yes, very good. See, surgery is very easy. Every line is just simple questions. So he developed a wound. Now you said developed a wound followed itching. Okay, it's because of the pruritus. So it is actually history of trauma.
Yes.
It's a traumatic reason. Okay, and slowly it is graduated over a period of time. History, sir has already asked. Altered sensation. Okay, Shreya, can we go to the next one, please?
Next plate.
Yeah, fever. Yes, you have very well answered. Is the most common symptom of deep vein thrombosis symptom. There is a patient says more than 30% is fever. The
Yes.
earliest symptom, most earliest symptom. The other things like swelling and pain are later on. Abdominal pain, distension, chronic constipation. So these are secondary causes. Yes, okay. No history of chronic cough. Why? Why did
Sir,
you ask?
one of the risk factor for varicose vein is rise in intra-abdominal pressure, sir. So I thought of that.
Okay, maybe the cause for Stephanovarix. That's what she's telling. Very
Safina.
common. Maybe more management. Okay, great. Okay.
Okay, prolonged immobilization. Okay, very good. Prolonged hospitalization, almost same. No history of previous surgery for varicose veins. You have already answered in the next slide. Shreya, can we go to the next one, please? Yeah, no surgical history, sir has asked you. The reason the answer is you are thinking of a new variety called recurrent varicose veins. It is there in the latest edition of Sir's book and Bailey also. You have to read for the exam because nobody nowadays they can ask the new stuff. Uh, Always try to be relevant to the problem. No history of diabetes mellitus, hypertension, asthma, tuberculosis. Do you think asthma and TB would be a predisposing factor for varicose vein?
No, sir.
No. If you write that, then we will definitely ask such a question. How it is? Now,
Then,
diabetes mellitus,
uh,
yes, you have an infective problem. This, if the patient is having DM, the chances of because it can coexist. Alle? The
Yes.
vascular system, it can coexist. Hypertension already we have, but there's arterial hypertension and not venous hypertension.
Yes.
We are dealing with venous. That's fine. Agreed. Shreya, can we go to the next one, please?
yeah, next slide.
Of this smoking and alcohol, do you think which of these can predispose to varicose vein?
Sir, due to smoking, the
Why?
patient
Why?
because collagen deficiency can occur in smokers, so there occurs venous wall weakening.
Vein. That is for artery, no?
Sir.
The problem with smoking is there's a drug that we give for the management for varicose vein nowadays. It's there in the book. The same reason is what the smoking is the problem. Viscosity. It increases the viscosity of the blood cells. It starts pooling. That is the main problem. Okay, very good. Alcohol has absolutely no role. That's fine. In ladies in personal history, is there any drug that you will ask for?
Yes, sir. Oral contraceptive
Yes,
pills.
very good. OCPs with different types. You have estrogen, progesterone, and mixing.
Progesterone, sir.
Which of this which will cause more chances of?
Sir, progesterone, sir.
Okay, right. Fine. That's good enough. So next one, please.
Next,
Family history. Is it relevant to varicose veins or is it for lymphatics or PVOD?
Sir, varicose vein also has a family history like FOXC2 gene mutation can run in the families.
Sir,
And
I think Nilanjana is in a hurry to go. She's answering all the questions before the question comes.
good.
Yes, very good. It is the maternal history that is valid, not the
yes,
paternal history. It runs in from the maternal side, and as you're right, it is the inheritance of the FOXC2 gene. Yes, very good. Yes, that's the problem. And like sir already said, when you say this, don't just draw the diagram. We draw the diagram in the answer sheet. You're telling us history. You have to say mother, children, which of these children was it the males, females, how many percent? That is very important.
You're
So, can we go to the next one?
next, Shreya.
Okay, summary, that's fine. So you have given us all the ideas of which system, anatomically, which system is involved, and from where to where the accident is involved, and what is the complication. Yes, very good. Yes,
And
sir.
avoid, so to avoid, try to use the word wound, better to
Uh,
tell
okay, sir.
ulcer. So let her go for a presentation, Robin.
yes, sir. Sir, just in Nilanjana's defense, she had put ulcer. I corrected it as wound, sir, because we have a habit here because ulcer they think it's a diagnosis because the patient does not say ulcer. They come and say it's a
But
wound.
what
Ah,
we
yeah.
think is they
Oral
can
cavity is a
that's
sore.
not
Yes,
the clinical
yes, sir.
technical
Yes,
word.
sir. So ulcer, it's good enough. Thank you.
Next, okay.
So this is the picture of the patient's legs. Next slide, please. Coming to the general examination, the patient is conscious and cooperative, moderately built and moderately nourished. The height of the patient is
Robin,
Yes, sir.
1 minute, sir. Manoharan, sir, from
Yes.
Pakula Medical College, Puducherry has joined. Sir,
Good evening, sir.
welcome, sir. Good evening, sir. Thank you for joining, sir. You can in between, you can also add on to the whatever your opinion, sir. I really welcome from the platform. Robinson, sir, also is there with us. Continue, Amma.
Good
Continue.
evening, sir. Good evening, sir.
Good evening, sir.
Good evening, sir.
Good evening, sir.
Nilanjana, continue.
Yes, sir. Height of the patient is 167 centimeter, weight is 70 kilograms, and BMI is 25 kilogram per meter square. Vitals, the pulse rate is 76 beats per minute, normal rate, regular rhythm, normal volume and character. Temperature 97.8 degree Fahrenheit. Blood pressure 130 over 80 millimeters of mercury in the right arm in sitting position with adult size cuff. Respiratory rate is 16 breaths per minute. Next slide, please. The patient has pedal edema in the left lower limb. There is no pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy. Next slide. Local examination. The patient was examined after taking consent and examined in the standing position. Both limbs were exposed up the level of umbilicus. Inspection. The attitude of limb is normal. There is no deformity. Gait is normal. Localized multiple dilated veins are present over the left lower limb in the posterior and medial aspect of the thigh, posterior aspects of the knee, and medial aspect of the lower two-thirds of the leg. Next slide. Skin over the left lower limb shows hyperpigmentation in the lower two-thirds of leg. Skin is not stretched and shiny. There is no hair loss, no brittle nails, or no loss of subcutaneous fat. There is no saphena varix. A single ulcer of size approximately 5 into 3 centimeter, vertically oval in shape, is present just above the medial malleolus. It is sloping, edematous, and it has sloping, edematous, and inflamed edges. The floor of the ulcer is covered with granulation tissue. There is no discharge from the ulcer. The right lower limb appears to be normal. Next slide. Coming to the palpation, there is no local rise in temperature and no tenderness. Localized multiple dilated veins are present in the over the left lower limb, posterior and medial aspect of the thigh, in the posterior aspect of the knee, and medial aspect of lower two-thirds of the leg. There is no thickening of veins and skin thickening is also absent. Next slide. Coming to the test, sir. Brody's Trendelenburg test 1 is positive, test 2 is also positive. Tourniquet test is positive. Perthes test is not done. Modified Perthes test negative. Schwartz test positive. Pratt's test, the blowouts are seen above the knee, below knee, and the lower leg levels. Next slide, please. Morrissey's cuff impulse test, expansive cuff impulse felt over the saphenofemoral junction. Figan's test, depressions are felt at the saphenofemoral junction, above knee, below knee, and the lower leg perforator sites. Next. Test for deep vein thrombosis, Homan's test and Moses sign are negative. Next slide. Palpation of the ulcer, a single ulcer of size 6 into 4 centimeter vertically oval in shape is present just above the medial malleolus. The ulcer has sloping, edematous and inflamed edges and the floor is covered with granulation tissue. The base of the ulcer is made of subcutaneous tissue. There is no induration. The depth of the ulcer is approximately 0.5 centimeter. Ulcer doesn't bleed on touch and surrounding skin shows hyperpigmentation. Next slide. All peripheral arterial pulses are felt. There is no palpable inguinal nodes. Sensations of the left lower limb are intact. Ankle joint movement is normal. Right lower limb appears to be normal. Percussion, Schwartz test is positive. Next slide. Systemic examination per abdomen. There is no distension in the abdomen, no organomegaly, no palpable mass over the abdomen. Bowel sounds are heard. Respiratory system, normal vesicular breath sounds heard over the lung field, no added sounds. Cardiovascular system, S1, S2 heard, no murmurs. Central nervous system, no focal neurological deficits. Sensory system, normal. Next slide. Summary. A 60-year-old gentleman who is a security guard by occupation presented with complaints of dilated veins over the left lower limb for the past 2 years, gradual in onset and progressive in nature, associated with night cramps and itching, and a wound over the inner aspect of the left ankle, initially small in size and later progressed to the current size of 6 into 4 centimeter. On examination, localized multiple dilated veins are present over the left lower limb in the posterior and medial aspect of the thigh, posterior aspect of the knee, and medial aspect of the lower two-thirds of the leg, with findings of saphenofemoral and perforator incompetence at above knee, below knee, and lower leg perforator levels. Next slide.
Okay. Continue.
Also, a single ulcer of size 6 into 4 centimeter vertically oval in shape is present just above the medial malleolus with sloping edematous inflamed edges, floor covered with granulation tissue. Depth of the ulcer is 0.5 centimeter. Base is made of subcutaneous tissue and is mobile, and surrounding skin shows hyperpigmentation. Next slide. Provisional diagnosis. Varicose vein in the left lower limb of secondary etiology involving the great saphenous vein with saphenofemoral incompetence and above knee, below knee, and lower leg perforator incompetence with complications of varicose ulcer and pigmentation. CEAP classification C5, ES, ASP, and PR.
Okay, we'll go back to the palpation. Freya, go back. Palpation. Go back. Okay. Why local rise of temperature? Briskly we'll go through it. One word answer you give.
Sir, in order to rule out superficial thrombophlebitis and...
Okay. And additionally, if this active ulcer, there will be local rise of. We know that no active ulcer, healed ulcer, it comes under the CEAP classification. Again, tenderness.
Tenderness also, it occurs in superficial thrombophlebitis as well as deep vein thrombosis, sir. So in order to rule out.
And it is once there is a periostitis, it will be tender. Okay. There is another reason. Dilated veins. Okay. Posterior which side and okay. Posterior aspect knee, medial aspect lower third of the leg. You can always here there is a controversy. Actually, we feel that ulcer, when you say rise of temperature, they are only ulcer you explain here. So everything ulcer, tenderness, local temperature, tenderness, everything. Then go to the dilated veins. Then straight away go to the examination for the veins, specific tests for the veins, all those tests.
Okay.
Then joint movement, then lymph nodes, joint movement, peripheral pulse, lymph node, like that in orderly fashion. If you go, it will be a flow, natural, actually lucid flow. It will be there in while presenting. I know it's a difficult thing in a varicose vein to go in a formal way. You are presented well. This is what we feel. There is some people think we should come ulcer first, then it will go like that. I think we'll just take Manohar's opinion, sir's opinion little later afterwards. Next slide. Right, how exactly you do Brody-Tellenberg test? Just because so many viewers are there, let them have the clear idea. Briefly you tell, quickly.
Yes, sir. For performing Brody's Trendelenburg test, first of all, we will make the patient lie in supine position and we will elevate the limb so that there occurs milking of the veins is done. And after that, we will tie a tourniquet just below the saphenofemoral junction, and then we will ask the patient to stand up. In test 1, we will remove the tourniquet, so we can see a rapid gushing of blood from above downwards, which indicates the saphenofemoral junction incompetence. In test 2, we will not remove the tourniquet, but keeping the tourniquet at the level, we will ask the patient to stand up. And we can see gradual filling of the veins from below upwards, which occurs in perforator incompetence, sir, which signifies perforator
When you
incompetence.
do second, you have to repeat it. Do it first, again empty the vein, apply tourniquet again, then repeat it.
Okay, sir.
Three tourniquet test is for what? What it means? Positive means
Sir, for perforator incompetence, sir,
we'll release the tourniquet from below upward or above downward.
from below upwards.
Always from below upward, never from above downward. Perthes test usually you won't do it. What is the modified Perthes test? How exactly you will do it?
Sir, in modified Perthes test, we will make the patient stand, and after that, we will tie a tourniquet just below the saphenofemoral junction. And after that, we will ask the patient to do jerky steps of brisk walking, and we will observe the leg region. And if there occurs prominent veins and the pain is also present, then it means there is DVT, deep vein thrombosis. If the veins are shrinking and there is no pain, then the deep vein thrombosis can be ruled out, sir.
The specification is what type of pain? This is the more relevant.
It's a bursting type of
Bursting
pain.
pain. What is the meaning of bursting pain?
Bursting pain means venous claudication is there, sir.
It's not the venous claudication. That's a different thing. It is the bursting of the dysphagia, because dysphagia is unstretchable. Its stretching capacity is less compared to the superficial fascia. So it is bursts as if it is tearing off. There is a bursting pain. That's
Okay,
why
sir.
they remove the tourniquet and release and get relieved of their pain. So bursting pain is very more relevant. And another thing you have to always add that you should never empty the vein.
Yes.
This is the test where you will never empty the vein, tie a tourniquet, ask the patient to have brisk walk, then they will have brisk bursting pain, then more prominent vein. That is what you look for. Never tie a tourniquet. This is the point you have to remember in modified Perthes test. Then bursting pain is very much relevant, which they express actually. Short test, how exactly you will do it?
For short test, sir, we need a continuous column of blood from the saphenofemoral junction to the lower leg region, to the ankle region.
Which suggests what?
Sir, saphenofemoral junction incompetence, sir.
No, it suggests what? It's not. It does not suggest incompetence.
A continuous column of blood.
It suggests continuous column of blood from the point of tapping to the point of feeling.
Yes.
So in between these point, there will be all for incompetent.
Yes, sir.
It is not a test for SFJ incompetence. It's a test from the site point of where you tap and from the where you feel. In between, all are incompetent. That's exactly. You won't say it suggests that SFJ incompetent. It need not be. Understood? So in always you have to do in standing. Pratt's test.
Pratt's test is for Pratt's test we will tie an elastic bandage from below upwards, and then we will tie a tourniquet just below the saphenofemoral junction, and then we will look for blowouts. So at the perforators we can see blowouts, sir.
When you release the bandage, you will see the blowout. You have always important point you have to remember is always you have to apply SFJ. You have to do SFJ tourniquet. With the tourniquet on, you have to apply the bandage. Then when you release the bandage, you can see the blowout. Next page, Freya. Mercy's cuff pimple suggests what?
Sir, saphenofemoral incompetence.
We'll do it in lying down position or standing.
First of all, we will make the patient lie and we will empty the veins, and then we will ask the patient to cuff, sir.
No, Morrissey's cuff impulse is done always in lying down position. It is not in standing position. Okay.
Yes, sir. Yes,
He
sir.
will elevate and empty, then ask the patient to cough. It is in
Yes.
lying down position. It's very, very specific and clear. You always see people will have confusion. It is in lying down position, not in standing. Am I right, Robin? If I am anything wrong, just correct me, Robin.
No, sir, absolutely right. Because Nilanjana is just like hernia, no?
Yes, sir.
In standing position, lying down position, we empty, you reduce the thing, and then you keep the thing, then you palpate for the impulse. Same. Yeah, absolutely, sir. Yeah.
Fagan's test.
So in Fagan's test, we will first mark the points of blots in the patient where the perforator incompetence is there. Then after that, we will make the patient lie down and we will pass our fingers through the veins and we can feel depressions at the sites of perforator incompetence.
Absolutely perfect. You have to, in standing, you have to mark the blowout. In
Yes.
lying down, which including emptying, run your finger and feel the crescent like depression. And mark it. It's a very good test for the marking the perforator. Next slide. Shreya, next slide. Right. Human's sign, Mohs sign, Linton sign, and these are the tests for deep vein thrombosis. Of course, it is all of you know that. Let's skip the slide. Next one. This is a ulcer. You have written everything. Does not bleed, edematous base. What I thought is mobility is important. You have put somewhere mobility because most of the time these ulcers are not mobile. It will be adherent to the bone. So that point is very, very important. And there will be some amount of periostitis. How will look for periostitis?
Sir, there will be pain at the region and there will be a deformity also, sir.
Deformity is not a feature of periostitis. It's the involvement of the, it is ankylosis. It is fibrosis. Deformity causes fibrosis. Whatever the Achilles fibrosis causes telepathic virus, whatever it is. It's not the cause fibrosis. Periostitis, you look for the, run your finger over the bone and you will feel the tender thickening. Thickening of the bone is the feature of periostitis. Okay, and tenderness. Next slide. Right, all peripheral pulse felt your return sensation, palpation of inguinal. Which group of inguinal lymph nodes?
So the vertical group,
Vertical group of lymph nodes. Ankle joint movement, you said. What are the movements of the ankle joint?
dorsiflexion and plantar flexion, sir.
Okay, subtalar joint movements.
Eversion and inversion.
Absolutely right, because this question is usually asked, students will get confused. And they'll say all four movements are by the ankle joint. So subtalar joint, inversion, eversion, ankle joint, only dorsiflexion and plantar flexion. Ankle joint will not participate in the inversion and eversion. Right lower limb, short test positive, you have told. So, Robin, you add on to anything else in the palpation? She has written properly. She had answered
Sir.
most of the things.
Manoharan sir, would you like to ask any questions, and then I'll follow after that. I'll give seniors can ask. I'll wait.
Yes, that's right. Sir, Manohar, sir, please.
Yeah. No, everything, all points covered, sir. He has answered very well.
Yes, sir, yes, sir, yes, sir. So, sir, then if the sir wants to say it is a final. So, Robin, you add on to anything?
Shreya, can you just go back to the exam? Just I want to revise for the other students. Sir, a lot of students have joined from Dubai. So,
Okay.
Shreya or Aditya, they want to ask them questions. How do we feel the questions
No,
they
that
want
at
to
the
know?
end we'll go through the chat and answer them.
Yes.
At the end.
Okay, sir.
In
Okay.
conclusion, we'll go
Please.
through the chat, Robin.
Okay. Yes, sir. Shreya, can we go to inspection? Nilanjana, you have covered everything, like how SRB sir and Manohar sir had said. Local examination of which limb, right or left limb. So it's clear to us. Okay. Patient has examined. That's all fine. Inspection of the limb. There are 4 points that you have to cover in inspection of any varicose vein limb. One, skin over the swelling, which you have covered very well. All the changes that you have seen. You have mentioned the signs of peripheral ischemia also very well. Starting from the hair loss onwards down to the loss of subcutaneous tissue. Absolutely right, with the nail changes also. So that's one thing. And the color changes you have mentioned. Two, anatomically speaking, which system is involved? Is it the great saphenous or the short saphenous system? Third point, is it that whatever swelling or dilatation that you have mentioned, is it a generalized problem or a localized problem? The third point. Because why is that important? This generalized and localized, what is the inference? What do we get? What do we tell us?
Sir, generalized means generalized edema can also occur.
No, edema. No,
No, not
I'm
like that.
talking about tortuosity, dilation. We are talking about
Dilation.
that only. What do you
Yes, sir.
mean by what do we mean by generalized? If you present to us, there is a generalized dilatation from somewhere to somewhere, or there is a localized dilation. What is the inference?
If it's continuous column, sir, and
No, no,
also
no, not continuous. No,
This means you have not
perforators.
understood the question.
it's a very simple thing. It's a third point is we want to know this dilatation. Is it, if I give you the clue, it becomes very easy. Is it starting from somewhere all the way going up, or is it localized?
Yes, sir. If it's only involving the perforator,
Yeah, so localized means supposing now if it's all patients will not have anything, all the great saphenous system from medial malleolus all the way. That is generalized swelling tortuosity. Localized somewhere below knee. Some people will have only the thigh. Agreed?
sir,
Yes.
yes.
Just for the revision point, what are the perforators that you have?
Sir, we have the Hungarian perforator in the thigh. Then
Yes.
at the mid thigh, we have the dots perforator.
No,
Then,
mid thigh is the Hunterian. The subsartorial one canal is the Hunterian mid thigh perforator.
okay,
It's
sir.
very easy. Either you go from below up or
Yeah,
from
we
above
must
down. Yeah.
tell, we always tell from below upward.
It's easy that
Like
way
Okay,
because
this
that
step was
alphabets becomes easy.
from below upward.
Yeah.
in the angle region, we have the Mayen-Kushner perforator. Then
Okay.
lower leg perforator, cockade 1 and 2, 1, 2, and 3.
Ah.
Then at the gastrocnemius muscle level, in the lower knee region, we have the Boyd's perforator. Then
No.
above
So
knee
you have 5, 10, 15 centimeters from the medial
centimeters.
malleolus, pocket 1, 2, 3. Agreed. So
Yes.
it's very easy. So that is a leg perforator, ankle perforator, below knee, above knee, mid thigh. It's very easy. Below
Below
knee,
knee,
yeah,
Boyd's
yeah,
perforator.
B for B, Boyd's perforator, and
Above
above dots.
dots.
That's it. Very good. Now one question. What is the name of the perforator other than your named perforator is very important clinically because all these patients, all their ulcers are around seen that area.
Sir, Mayen.
May and custards are ankle perforators, something else in that region.
Sir, I don't know, sir.
Somewhere near just few centimeters above the calcaneum. It's around that always this
Para,
inframalleolar area is very dangerous. It starts there. All these the classification CEP starts there. All the spider veins, reticular veins, telangiectasias start there and then gradually go up. No?
No,
the para Achilles vein.
The para.
Right.
So then she has, yeah, okay. So that is the third one. And the fourth point on inspection is the impulse on cuffing. The Morrissey. That's it. Shreya, can we go to palpation, please? I will just rush through. Sir has asked all the questions. So on palpation, local rise of temperature, tenderness, skin over the swelling. Same. So you have ruled out SVT, you ruled out DVT also.
We
yes.
thought
Or
come here.
yes, no thickening of veins, no skin thickening. We didn't get that point. What do you mean by thickening of veins, skin thickening?
Sir, if the veins are prominent, like in superficial thrombophlebitis, and skin thickening is to rule out lipodermosclerosis, sir.
Okay, I think from the picture, it's quite clear that the patient is having lipodermatosclerosis. Alright.
Yes, sir. Right.
Okay, and something else. On inspection, you did not mention that. Shreya, can you go back to the picture of the patient's leg? Yeah, wait. Can you see around that ulcer, which you have clearly mentioned that there is hyperpigmentation? That's
Yes,
absolutely right.
There
What
is
is that? What is that whitish discoloration that you see above that ulcer? What do you call it?
sir. Is it eczema?
no.
No,
It's
eczema is
hyper.
not a sign.
What else is there? There is something else is there.
What is the what is that color and what is the Latin name for that color?
Yes, sir. Phlegmasia cerulea.
No.
Not phlegmasia. Don't go hyper. I told you, take some time, 3 seconds, 5 seconds, and answer the question. Always look carefully. The clue is there. You have a varicose ulcer.
What is that whitish color?
What is the sir is given? The clue is there. The white color. What is the name of that condition? What is white for Latin?
Alba, sir.
That is there. Alba, that is a different thing.
It is a different condition. The phlegmasia cerulea alba is because of DVT of veins.
DVT.
That's deep vein thrombosis. What do you call that? This is very
Yes,
common.
sir. Atrophic.
That's it. That is the thing that you see in this patient. It's blanche. It's blank. It's completely white. It's atrophy tissue. It's fibrosis and hyperpigmentation around that area. Okay, that you didn't mention in the skin. That's very good. Shreya, can we go to the palpation? What do you call that black line that is running on that leg? So can we go to that image, please? Just to show them. Yeah. Or the second image, you see a black line that is running in the second image. What do you call that? Now you have said this patient's history is 2 years. Yes.
Yes, sir.
He is a chronic smoker also, you have said. So let's say
Yes.
he's having PVOD also. The minute you ask this, when you are trying to do the test of Brody, Tendelberg and all that on palpation, you have elevated the limb for passive, you have milked the vein. What will you feel? And this black thing, what do you call it?
What it is called as?
What do you call it? When you can
All
feel it.
those,
It's, yeah, this is a
terminology.
classic case. Classic case.
Uh,
When you empty these long-standing and chronic history varicose vein patients, you will get to feel something. And these patients also have arterial problem also. What do you call that? Pass?
yes, sir.
Guttering.
Yes.
Guttering
Vein
of
guttering. Guttering of veins.
vein disease
Classic.
in the perivascular disease, arterial disease.
Any problem in arterial system, this sort of thing you will classically see because veins also have nothing more left.
Artery won't collapse completely. Only
Yes.
partially collapse. But in a perivascular disease, it will collapse completely. Okay.
Shreya, can we go to the palpation slides? Yeah.
Continue, Shreya. Continue.
Yeah. Next slide, please. Next slide.
Okay, continue.
No, thickening, skin thickening is there. Okay, your test, sir, is already covered. Brody, Tenenberg, test 1, test 2 for SF junction, perforators. Absolutely right. You know how it is done. Inference also is clear. What do you call this tourniquet test? You have, how many tourniquets did you apply?
Sir, 4 tourniquets, sir.
4 tourniquet. It's called 3 tourniquet test or multiple tourniquet test. What is the name of this multiple tourniquet test? If you don't know, you can pass. Please write down the question, and then if I tell you the answer, you will not search for the answer. Please, no, pass.
Yes.
It's a 3 tourniquet or multiple tourniquet.
Yes,
3 or more tourniquet.
the multiple has a name. This just like Brody, Trendelberg, Perthes, modified, which has a name. If you don't know, you can. It's homework for you.
You can
Next.
refer my book, no problem.
Yes, the Perthes test, modified Perthes test. Both of them are for deep vein thrombosis. Of these two, which is the confirmatory test for DVT?
Sir, it's a Perthes test.
No, modified Perthes is the confirmatory test. Perthes test
Perthes is not done usually.
Not
Yes.
done for postgraduates. We generally don't because we suspect findings of DVT and then we only confirm modified Perthes. Now, as you know, Perthes test, the patient is standing. No
Yes.
milking, no emptying. You tie the bandage. You ask the patient to walk and come back. The patient will say he is having severe pain. So it gives you a clue that the patient is having deep vein thrombosis.
Yes.
Modified Perthes test. What are the changes that you will see in the patient? 3 changes and finish it off.
So bursting pain will be there.
You tie the tourniquet after emptying or no?
Not after emptying, sir.
You ask the patient to stand up in full-fledged, dilated torches elongated completely. You tie it at this SF junction, and you ask the patient to do frog squat or some brisk walking. And what are the changes? One,
First one, the patient will have pain, sir. Bursting.
what type of pain? Severe bursting sort of pain. Okay. Second,
Then the veins will become prominent.
which veins will become prominent?
The perforators.
No,
Sorry, the deep veins will be prominent, sir.
deep vein. Now there's only one more classification left.
No, sir.
Your
Yeah.
deep vein is thrombosed.
Thrombose. So the superficial veins are
Superficial
getting.
vein, common sense only. It's very simple. You are tying it that the blood can't flow anymore.
Yes, sir.
It becomes more prominent. It becomes more prominent than what it was before. That is the second one. Yes. Third one.
Prominence of calf.
Calf swelling. There's no
Yes.
prominence. The swelling of the calf. That's it. 3 classic inference. Very easy. It's not. So once you have confirmed, but very dangerous test because there are high chances that the patient will develop pulmonary embolism. You ask the patient to do brisk walking, he will never come back. Shorts test, classically, as in it's there in Das also in SRB's book. It's a percussive test. It is not done here. Also, the catch is it should be a long column from medial malleolus all the way to SF. You keep your thumb there, you tap it at the bottom, you should feel this vibration all the way up. Okay, the thrill. Pratt's test, Fegans. Shreya, next slide, please. Pratt's, yeah, okay, very good. Fegans, calf impulse. Okay, next slide, please.
Say next slide.
Next slide, Shreya. Yeah. Test for deep vein thrombosis, you have mentioned Homan sign, Moses sign. There is one more sign.
Neuhoff signs.
Neuhoff sign. None of these signs are specific or sensitive for deep vein thrombosis.
There is one more sign, Linton's sign, that is SFJ, you tourniquet, and apply this
Yes,
one
sir.
become
The
prominent.
Linton's test.
All these signs are
Yeah.
Mainly of academic interest, may not
That's all.
have a clinically much useful.
The classically you will see this only in acute DVT. It you
It's
will
not
not see it otherwise.
which are
Okay.
acute DVT.
Acute deviant thrombosis. Shreya, the next slide, please. Yeah, palpation also she has covered everything, sir. So it's okay. The base of the ulcer, like sir said, the mobility is important. The
Okay.
floor is something that you see just for the sake of second years. Floor, base, edge, margin. These four things you have to know the difference. Two are on inspection, two on palpation, and this is fine. Surroundings in hyperpigmentation, yes. That is a bit of a controversy. In your last slide, you did not mention that skin thickening and all that. Here it is there. Okay, reason for hyperpigmentation is clear. Shreya, next slide, please. Schwartz, okay. Next, Nilanjana, last question. Any role for auscultation in varicose vein cases?
Yes, sir, there is a role because if there is an arteriovenous fistula, then we will get a machinery murmurs.
Yes, very good. That is the only that is only in AV malformations like a fistula. That is the only time you will get this. That is machinery murmur. Is there any other place, any other sound that you will get?
Louis, sir.
Yes, you will get a venous bruit in cases of long-standing ones. When there's stenosis, you will guess. Absolutely right.
Venous
Yes, very
hum
good.
it is called, venous hum.
Yes,
And
yes,
additionally, in a young individual, you may have to measure the limb length and girth, especially if varicose veins are the common finding in AV formation, involving more entire part of the limb or main part of the limb. So girth will be increased and width length will be increased. So you have better to measure the limb such situation, not in this patient. Okay, so measurement often may be required. So next
next slide, Raj.
slide here.
I think it's over. Summary is over. And Nilanjana, just for the sake of completion, only if you have time, you answer. Otherwise, no. Can you give us, sir? Just now said something. You have to measure the girth. Why did he say that? Are you suspecting some other condition? Because
Uh,
in classification of varicose vein etiology, you have primary and secondary. In
yes,
primary, you have congenital also. That is the last clue. Can you think of something where the girth is important? Where you have varicose vein. Sir has already given
This
clue.
is
Young
important.
yes,
patients.
sir. Klippel Trenoni Linder
The
syndrome.
Klippel-Trenaunay syndrome. There are three syndromes in varicose vein chapter you should know. One is Klippel-Trenaunay. Second one,
Park-Weber syndrome.
Park-Weber syndrome. Third one, aha, this is something to do with thrombosis, iliac veins. May-Turner syndrome. Yes, very good. Kolar.
Okay,
Yeah.
next,
Okay. Okay, sir.
go to the next slide.
Yes, sir.
Yeah, right. Summary. You said wound. This is ulcer. That is cleared. And when you okay, next slide will go.
Yes, sir.
Diagnosis will go.
Yes, sir.
Mm, next slide. There. Right. When you give a diagnosis, better to put ulcer. Ulcer in the venous ulcer in the leg, which is not healing or healing whatever way, and then due to saphenofemoral incompetence, which are with or without perforator, whatever it is, with pigmentation or CAP classification you have put, side you have to put, and you can add on to no features of the features of the DVT. You can add on to that. Explain CAP classification.
Sir, C stands for the clinical sign, sir. First of all, C0 means that there is no venous signs present. Then if it's C1, then telangiectasia is present. C2 means there are varicose veins. Then C3 means edema is present. C4
Okay,
means,
E stands for what?
sir,
E for what? E for what?
E,
Oh, what is the Latin for cause, sir?
E for etiology,
Etiology.
yes, sir,
Ah,
etiology.
anatomy.
etiology.
Okay,
Clinical,
written there.
etiology,
A
anatomy,
for
and
anatomy,
pathology.
yes.
Yeah.
P for pathophysiology.
Yes.
PR means what?
PR means pathology is reflex, sir.
Reflex. Okay. ASP means what?
ASP means anatomically it is the saphenofemoral junction as well as the perforator incompetence is
Right.
present.
In this patient, short saphenous vein is involved or not?
Uh, cannot say like
Have you inspected from lateral side? Have
yes,
you
sir. There is no dilated veins in the lateral
Okay,
side.
if there are no dilated veins, it's okay. If there are dilated veins on the lateral aspect, then you have to do a tourniquet test for short saphenous vein and confirm. Otherwise, clinically, you will miss it. Okay, if
Okay.
there are dilated veins on the lateral side, it is better to elevate the limb, apply a tourniquet just below the purple fossa. Then is it very easy to do rather than like a limber test with some confusion. Here, technically very easy, but you have to do it. Then release the tourniquet, then we can see the reflex.
Yes.
Okay, so CAP is over. All students can go through the book and learn because it is not a platform. We can explain it, I think, Rob,
Yes,
right?
sir. Yes, sir.
So it is important currently, it's a short note also, detailed CAP classification you should remember. Just before the exam, we can memorize it. Difficult to remember many times. Okay, so sir, Manoharan sir, we are done to the diagnosis. Before going for investigation treatment for 10 minutes, just your opinion, just to tell for the
Yeah.
clinical exam, anything to add from
Everything,
our side.
everything she said, whether it is primary or secondary, she has to say.
That's what in provisional diagnosis clinically you should be able to tell whether it's primary or secondary. So what do you think in this patient, whether it's primary or secondary?
Sir, it's secondary to prolonged standing because he's a security guard by occupation.
Okay, it is because of his occupation,
Yes.
secondary to prolonged standing. Okay, that's what you have to mention. So secondary type better to mention, like sir rightly told. Okay, right. We'll go to the next slide, Robin. We'll go for the
Yes, sir. Yes, sir.
investigations.
Nilanjana, just make a short note. Sir, as he mentioned, other than long saphenous, always try to examine short. Usually for postgraduates, we ask this. There is a tourniquet test that we do there, and you look for the sudden filling of blood also
Okay.
with the thumb or with the tourniquet. Just make a short note. If they ask you, you know how to do it. Okay.
Okay.
So next slide, Freya.
Excuse me, sir. The photograph should have both limbs, sir, preferably.
Yes,
Yes,
sir. Yes, sir.
yes, yes, sir.
We
Yes.
should have comparison always. She has mentioned right limb is normal, but you should have a photo when you put. Okay,
And
that's absolutely right.
definitely, the photo shows below knee there is a lot of wasting and the difficult deformity is also there.
Yes, sir. Yes,
Robin sir has correctly pointed out that venous guttering is also there.
Yes, sir. I must apologize on her behalf. I took the photograph of my patient, so she didn't get time to do it, sir.
Patient has,
Robin
patient
is very honest.
has,
I appreciate.
like bermuda is also very much there.
Yes, sir.
But there, yes, sir. It is there.
Yes,
Absolutely.
okay.
So investigations, just to go through the investigations and just to give a reason why you want to do.
Yes, sir. Apart from the basic routine investigations, I would like to do a duplex ultrasound scanning.
Right here, one word you should give a full form. I think last week I told, sir has told actually, Venus Doppler with the B mode duplex ultrasound scan. Like that,
Okay.
full form would tell. B mode is brightness mode.
Yes.
You should tell full form. Okay.
Okay.
Venus Doppler with the B mode duplex ultrasound scan. What is the invasive or non-invasive?
Sir, it's non-invasive, sir.
What are things we look for?
Sir, I will look for the venous flow, then the saphenofemoral junction saphenofemoral junction incompetence,
But what is the
perforator
important thing?
incompetence,
Most important thing we look for.
reflex also.
No, no, no. What is
Most
the
important
most
thing.
before
Everything I can
you're
make
a
out
surgeon?
clinically.
Yes, you're a surgeon. What you want? You want to do something for this patient for
Yeah, I
2 years.
have to confirm that this is a case of varicose vein.
No, no, no. Already you have clinically
All these
diagnosed.
things we can see clinical. It's very
Ah,
obvious.
what is something you are not sure of? You want to before
Deep
touching.
vein thrombosis.
Ah,
Most important is the first thing you have to tell
of
is
course.
deep vein thrombosis. Other
Yes,
things are very clear. Even though they'll give the report, it is clinically obvious. So
Okay, sir.
DVT you have to look for first thing. That's the most important thing because
Yes.
clinically and management wise and legally also very important. If there's a DVT, you will not operate. You will avoid operate, postpone whatever it is.
Yes.
Legally, it is very important. Okay, right. Culture discharge for bacteria. Ultrasound scan abdomen for the cause. Agreed. Any other thing you want to add on to Robin?
Nilanjana, you have an ulcer which is not healing since more than 6 months. WHO classification for a venous ulcer, I mean ulcer which is not healing is more than 6 months, more than 3. What else you are? It's not healing. You have tried all treatments. Something is missing here in investigation.
Sir, a biopsy.
Yeah.
No, biopsy. That's 1 second. Investigation.
Anything else you want to do? You said
On palpation, like sir has mentioned, one clue is there in palpation. Sir has specifically pointed when you palpate that leg, you will find thickening somewhere.
thickening suggests what?
Something somewhere.
Bone.
What is that? What is that structure? You will.
Thickening and tenderness suggests what?
Sir, it's a
Don't you want to
lymph
take
node.
X-ray? No, no, not lymph node. Don't you want X-ray of limb?
X-ray of the limb.
Yes, sir.
To see
Periost.
periostitis.
You want
There is
X-ray because you have a chronic non-healing at all. That's one. The rest is correct. Okay, duplex ultrasound, culture of discharge, and a wedge biopsy.
wedge biopsy from the
Wedge
edge.
biopsy.
Why you want to do wedge biopsy?
Sir, to rule out malignancy.
Which malignancy?
Marjolin ulcer, sir.
What is
No, that is not a malignancy. What? That's the name of something. What is the name?
Squamous.
What type of squamous cell carcinoma will you see under the microscope? Very quick because investigation then treatment. That's all.
What type of malignancy it is? Microscopically.
Keratin balls.
Basal cell or squamous cell? Which one?
Sir, squamous cell carcinoma.
Squamous cell carcinoma. What is the type of squamous cell carcinoma you expect to find in a varicose ulcer or a venous ulcer?
Very, very well
Very well differentiated.
differentiated squamous cell carcinoma.
It will not be
doesn't
poor.
spread
It
through
will
lymph
be
node
different.
or through the blood. Locally malignant. Now, which type of scar turns into marginal ulcer?
Some non-healing.
No. Specific
what?
scar.
Scar.
You have to remember that it is the unstable scar. Scar may be stable or unstable. These scars are unstable here. Unstable scar of long duration turns into marginal ulcer. This is a type of very well differentiated squamous cell carcinoma. It carries very good prognosis. Understood? So, word unstable scar and long duration. These two words are very, very important. These stars only will turn into marginal ulcer. Okay, let's say wedge biopsy is important. You would add on to that. X-ray is important. You have written a chest X-ray, but you have not written foot X-ray. That is also very, very relevant, right? Professor Robinson has told rightly. Okay. Sir, Manohar sir, anything to add here? Investigation, most of the things she has added. Discharge, everything she has added. I said full form B mode Doppler scan she has to write. X-ray foot, of course. Currently, in a good setup, vascular setup, they may do MRI, but X-ray, if they say that is sufficient, I think. Robin, correct?
Yes, sir.
So we go for the treatment, sir. Robin.
Nilanjana, last question in investigation. If you have a patient who has been operated for varicose vein,
Yes, sir.
and your diagnosis now is that is more than, there are 30%, 10 to 30% of cases who have been operated, they come back after 10, 15 years with what we call recurrent varicose veins. In such a case, what investigation would you like to do? Better than, make it fast.
Any non-invasive, invasive investigations you want to do?
Invasive or non-invasive? Decide.
Sir, is it venography?
No, I never ask the examiner, is it? You have to say.
What you want to do, you tell.
You tell, that's all. Venogram. You do a
Venogram.
venogram, that's it. You don't use it anymore. Varicography is already outdated, it's not there. You have a
Venogram. Registrophy is a non-invasive type, and ambulatory venous pressure again it is the invasive type. Venogram we can do. Varicography you don't do now currently.
Don't do anymore. Venogram. Yeah.
All those things are selective investigation, not in every patient. You have to really select, individualize, and you have to select. Okay, so you have to keep it in the back of mind. You should know briefly. You should know the meaning of this terminology. Remember, plasmography is a non-invasive. It is difficult to remember how to do it. You can always go through it, and exams also may have to read and ask question how to do it. And ambulatory venous pressure is an invasive one. And venography is an invasive one. Varicography, you don't do it, like he rightly told. Of course, most of these things are in a selection only will do, not in a regular day-to-day basis. I think.
Sir, may I ask last question just to cover that point also? Varicose vein, we all know, deep vein thrombosis, we know the investigation, yes. Supposing a lady comes to you with severe abdominal pain and pelvic pain, and they have isolated varicose veins over thigh and all that, but not full blown. What is your diagnosis? Severe pain.
Thigh pain, everything. What is it called as? What syndrome it is called as?
Lower abdominal pain. Better, make it fast. And what is the investigation that you want to do?
Especially in females.
Females. What do you call it? Is there in the new edition Bailey and SRB search book. They can ask you anything they want for theory.
Specific it is.
Sir, I don't know. Sir.
Okay, no problem. It's called pelvic congestion syndrome, PCS.
Pelvic congestion syndrome.
The pathophysiology is something to do with the pelvic veins. Okay, and the area in the perineum. And when you examine, that area will be having varicosities in that place.
And so all para-ovarian, para-uterine veins also getting congested actually in this case.
Yes. So in such cases, you always go for duplex above, not below. You go for abdominal and transvaginal. Yeah. So, sir, I'm done, sir.
Yeah. Okay, we'll go to the treatment.
Yes, sir.
Next slide, Saya. So you have written what is suitable to this patient. You have to tell. You have given the list of it. You have given the theory of part of it. This patient, what is it to tell? What you are going to do this patient? That's what probably I think Professor Manon sir will expect you to tell.
So for this patient, I will go for a surgical management.
I'll give the report. No DVT. Whatever the veins you are told, growth surplus vein and few perforators are incompetent. Below knee, perforators are incompetent. Maybe cocket and below knee. And with an ulcer. Ulcer already you have seen the picture. No DVT. SFJ and perforator. What is your treatment?
Sir, I will go for the
Yeah,
surgical
question is
management.
negative. Tell
Sir,
me,
I will go for the surgical management
like,
uh, because first of all, I should treat the ulcer.
there is a controversy, but you have to whether you treat ulcer first, whether you treat vein first. If you don't treat vein, venous embolism, venous hypertension will not be corrected. Whether you don't treat ulcer, there will be a ulcer may not granulate well, and so which one you will do first?
It is just like the question they ask for hernia and prostate. Which one will you do first?
You will do first like that. It is okay. So there is a controversy. You can do it together currently in the Venous Association of India and World Venous Association. They say that, but you admit the patient, treat the ulcer with all those methods. What is the method? How will you treat that?
Biscard
What's the
treat.
spelling?
BISGARD, sir.
G-double-A-R-D.
Yes.
Double A, not single A. Remember, Biscard method, elevation, passive activities, all those things I'm not going to tell. You can read it. Then once it granulates well, of course, send culture, antibiotic, use all those things, whatever the different methods of dressings. And then along with that, treat the varicose vein, then put a graft. Immediately also you can do that. Now, what are the different methods of treating the varicose vein?
Sir,
But if you put only graft, venous hypertension you won't control. Then the ulcer will recur.
okay.
So tell different methods of treating varicose vein, briskly, briefly.
Yes, sir. The surgical option which is available includes a Trendelenburg procedure with stripping and ligation of the perforators. Then we have other modalities like radio frequency ablation. Then endovenous laser ablation is also present. And the earlier used method is a sclerotherapy was also used, sir.
Now also it is used, not earlier. It is a standard treatment protocol. Now in a given varicose vein, it's not the one procedure. You do if you want to do SFJ ligation is called as prostatectomy, and currently Venous Association actually is against SFJ ligation, but at your level you should tell the Trendelenburg operation. And plus stripping of the vein, either extraluminal or intraluminal. Extraluminal is the Meyer stripper, intraluminal is the Codman stripper. Codman stripper. So that is what you have to tell. Then multiple perforated ligation or avulsion, multiple avulsions. Then you can add on to the sclerotherapy by selecting. So always you have to do the venous hemodynamic mapping using the proper Doppler.
Okay,
Once
sir.
you do the mapping, mark the vein, then decide what procedure. It is a combination procedure, not a single procedure. Understood? So, what is the problem with the SFJ ligation? Is revascularization and epithelialization. So, there is a problem with the SFJ ligation operation. But at your level, undergraduate level, it is accepted. You have to know how to do technically juxtafemoral first ligation of the long saphenous vein, very close to the vein there. And with all named and unnamed perforators, you have to ligate. Then put a Meyer stripper and ligate. You should be careful about the saphenous nerve. Should not injure that. It may cause saphenous neuralgia. Of course, add on to the foam sclerotherapy to the SDD or canal, and then of course multiple levels of service. It's a combined procedure, not a single procedure. That point you have to always remember. Okay. The Trendelenburg operation detail they may ask because it's a long case, so you should be able to mention the incision, how to reach that, how to identify, then how to ligate. Also briefly, you should know the technique. Of course, laser is a very good procedure. 1470 nano NM is a useful one. I use regularly laser for most of the varicose vein with the foam sclerotherapy. So these are the newer things you have to remember, newer methods for the varicose vein, how to treat. You have to remember the list of so many things that are there in my book or any book. You have to remember that. You have to recapitulate and express in the exam. So, sir, add on to anything treatment aspect.
Sir, you have covered everything, sir. Okay, nothing is left.
Grafting, you have to add once it granulates, you have to put a grafting. From where you take the graft? What is that graft called as? Name of the graft. Start with the T.
Is it split skin or full thickness?
Split skin. Split skin. What's the name?
Which one? It is very easy to remember. One is named after an animal, and that animal is very vicious, so it will eat too much. We don't need too much. We want only split this skin.
Split skin. It's a theist graft. THIERSCH. You got a theist wiring for rectal prolapse also, but it's a theist graft. Okay, usually thigh is the one. Humby knife is used. I got electrical dermatome also for that. Okay, so all those things you have to read because that will be asked in the exam while discussing the treatment aspect. Here, it is the surgery is the treatment if there is no DVT. Of course, treat ulcer with all those Bisegard method. Then whatever vessels, how based on the Doppler report or mapping, it's called a mapping. Venous hemodynamic mapping. That mapping you should do. Then accordingly you treat. Okay, so that is the treatment strategy. So next slide, Shreya.
Nilanjana, what are the tributaries that you will ligate in Trendelberg?
Yes, sir. We
How
have
many? How many?
six, sir.
Six. Oh, I know only five. Can you tell me the sixth
I
one?
don't add it on. Next time I have to add in my book,
Yeah,
Robin.
can you give us the sixth one? Three of them are the same. One goes up, two goes so star pattern. The other two are, I assume, antero,
Lateral and
lateral, and
posterior.
posterior needle. Okay. Which is the sixth one?
Deep external pudendals.
No, external pudendal that is added. Now, just because you asked this, when
Yes,
you
sir.
are doing the
Necessary.
stripping, where will you? That particular vessel is the reason for brisk bleeding when you are tying at the flush ligation. Your deep external. Ah,
Yes.
okay, but that's okay. Very good. It's fine.
So that's
She has
so
put all six.
Trendelenburg operation at UG level they should know, even though there is
Alright.
a controversy about it
Yes.
for the as of the venous association is considered.
Very good. She has answered all that.
So
Yeah.
most of the things.
Nilanjana, the last thing in recent advances in treatment, if you want in theory only, not practicals, endovenous glue is there. Just like our Fevikwik, the same matter, but medical glue, cyanoacrylate.
I know same thing what you use it can be used. Okay,
Yeah, there are
so
two types, butyl and octyl. So that's all it. Other venda, no need. That's no need for you. Just for
so
completion. Yeah.
sir, anything to add on to sir?
Yes, sir. Everything covered, sir. I have nothing to do. Robin
Robin,
and
Robin, I quickly go through.
she
Yes,
has
sir.
answered very well, sir. Very best wishes to her.
Yeah, she has prepared well, presented well.
Very good.
Definitely thumbs up for her the presentation. Very good. She was
Yes, sir. PG level.
Robinson had trained her very well. Good.
No,
Yes,
no,
sir.
sir. I did not do anything. She is very good
She
student.
presented very well.
I,
Good.
I have hardly seen. I only saw
Yeah,
her once.
I,
I
I,
asked her if
I
she's
have
willing
gone
to
through her
present. She
slide and
presented. I didn't help her at all.
she has presented well, summary, everything. This is the way to make a case sheet, write a case sheet. This is the way to write. Always, for all students who are hearing, long case sheet should present like this. Chief complaint, present illness, past history, family history with the family tree, then summary of the history, then the general examination, inspection, palpation, standing, she has mentioned. It's very, very important. And then, of course, summary, final diagnosis, and justify a diagnosis, then investigation treatment. Always they have to write investigation brief treatment for all long cases. I've been telling to my students, should include always. So that's the point. She has included everything. She has done excellent. Robin, I'll just go through my slides for a few
Yes, sir.
minutes.
Yes, sir.
So that will have the highlight. Shreya
Yes.
will go through my slide.
Yes, sir. Sir, there are some questions, queries
Yeah.
from some students. I'm not sure how to
So
answer them.
chat will open up once we'll finish the thing.
Okay, sir. Okay,
I'll
sir.
just share next slide. So just run the this one, Shreya. Okay, this is the topic, and this is the definition. Dilated, tortuous, elongated superficial veins. It's inelastic, pouched, friable. It's inelastic. It has permanently lost its functioning capacity. That's the point you have to remember. It's very, very common, 20%. The meaning of the great saphenous vein, small saphenous, which is earlier we were calling it the long saphenous vein. Now it is called the great saphenous vein, small saphenous vein. You know, the communicating veins are different from the perforator. This point you have to remember always. Communicating veins are communicating in the saphenous compartment or subcutaneous plane from the great saphenous to short saphenous vein. That's called communicating vein. From the posterior arch vein, on the posterior arch vein of Leonard communicating from the lower part to the great saphenous vein or short saphenous vein. There are so many communicating veins in the subcutaneous plane. They are communicating veins. They may or may not be having walls. Whereas perforator veins are always communicating from the superficial to the deep system. It perforates the deep fascia. That's why it's called perforator. So there is a lot of confusion and about these things. Do not get confused. The perforators are different. Communicating veins are very clearly currently it's a defined entity in the surgical anatomy of the venous system. So perforator already it is discussed. Robinson has discussed detail. Basis, Paraclis, May, Kistner, Pocket 1, 2, 3, boys, dots, hunters. Diagram is there in my book. We can go through that. Communicating with Giacometti communication mean is it's a common MCQ question for the NEET exam. Remember, what is the communicating vein between a long saphenous vein and short saphenous vein is called as from the uppermost part of the short saphenous vein, small saphenous vein. It goes upward and joins just before the ostia. That is called Giacomin Crulier communicating mean. It's a common MCQ question asked. Again, anterior accessory gets up very commonly there medially, and it is also commonly involved as a varicosity. So these are the two communicating means which you have to remember. Next, let's say to name it's the occupation. Already Robinson has discussed very clearly. Occupation is very, very important. And these are the complaints of exactly right, night time, all those things that we have discussed. Features of complication is there, just add on to that. Next slide. Fairness, this is the history. All those things that we have discussed, just highlighted. Swelling around ankle, pigmentation, ulcer, bleeding, like bleeding. Sometimes bleeding will be the history of bleeding is important. There's an indication for surgical intervention because they bleed during sleeping, they bleed, they'll be maybe exsanguinated. Somebody not want to observe that. So that requires surgery. You have to advise surgery patient present with the bleeding varicose vein. Remember, pain reasons already discussed. Major surgery, pregnancy, smoking. Why it is so already Robinson discussed very nicely actually. Family history, generation, family tree, already we are told. Diabetes, asthma, of course, for a completion of mistake, you add on to that. Anticoagulant drugs, very important. Many times they may be having anticoagulants, maybe added relevance, especially cardiac drugs when they are on. Next slide. Here, next slide. Examine disease limb first. Examine both limbs in standing and lying down. It's very important. Right in the case sheet. Exams is done in standing and lying down. Underline standing. It's very in both hernia and varicose vein. You have to examine standing and lying down. That part is very, very important. You are right in the case sheet first while starting examination. These are things infection, dilated vein, sapena varix in the junction, skin changes. Maurice's comfortable is lying down. Nilanjana. It's not in standing. Okay, ulcer, swelling, gaiter steer. It's called gaiter steer. The gaiter, no, military people they wear the this coverage around the ankle. That area is gaiter area. That's where chronic venous hypertension occurs more than 80 meter mercury. So venous pressure occurs. That's why it is called gaiter area. Very typical area. All complication occur. So that area you should remember meaning hand breadth around the ankle, middle and lateral malleus. That's the area, gaiter area. Of course, palpation, bone thickening are highlighted. Suggests periostitis percussion soft, and this is the Chevrier percussion is the in standing. Counterpart of Mercy is the cuff impulse percussion is in standing it is. Then test for DVT, not very significant, should know because academic in the exam they will ask. And Brody discussed the tourniquet test. It is the name I think Robinson wanted.
Yes, sir. Absolutely. It's
Owner's test.
Oshno-Maharnas test.
Yes. Parts taken test. I have discussed the cruvier cuff impulse. It is the cruvier cuff impulse in standing. Maurice's cuff impulse in lying down. Very clear. Same cuff impulse, cruvier cuff impulse in standing position. Maurice's cuff impulse in lying down. Maurice is the more important, commonly checked. That is in lying down position, not standing. Remember. And next slide here. And measurement of limb length, marking perfect mapping, it is called as. Auscultation already Robinson has discussed very clearly. Venous sum, Brui, and peripheral pulses is very, very important. Inguinal lymph nodes. You had mentioned inguinal regional lymph nodes. Joint, ankle, subtalar, active, passive, both you had mentioned. Opposite limb, gait, exam, abdomen, other system. And give complete diagnosis. Venous ulcer, right leg, midlateral, right ankle due to incomplete GSC, BK perforator. No evidence of DVT clinically. So complete diagnosis, your size, side, and complete diagnosis. This exactly will give the detect that right pitch, detect that you will follow. So this is most of the things you have written properly. Maybe viewers should go through her case sheet definitely. I think, sir, Manohar sir, I think she has written very nicely actually. Better than postgraduate, I feel. Robinson, I'm not against postgraduate course. That's the thing. So next slide. Let's say so I'm just this is the venous Doppler with the B mode duplex scan, full form you're right. Blood test, ultrasound, ECG, echocardiography, X-ray part. X-ray part already Robinson told important. And discharge study, veg biopsy from the edge, special tests, whatever that. Not commonly done phlebography has told. Operation element, sufficient like stripping, eversion, laser, RFA, endoscopic surgery, clearotherapy, all those things. Briefly, just wanted to highlight you people. These are things you have to know. Split skin graft, chest grafting it is, and treating varicose vein accordingly. Whatever. Now it's a combined modality, not single method. So this is the treatment aspect. Next slide, Shreya. This is the if you ulcer see that atrophic blanchard. This is the reticular. You know that dermal vein thread vein is less than millimeter. Reticular vein is subcutaneous, that's a 3 millimeter. More than 3 millimeter varicose vein, ulcer, different ulcers, these are long steps. Next slide, Priya. So this is so much bunching of the varicose veins. Is that a chronic ulcer? Lipodermatosclerosis, the like Manoharan sir rightly told, typical pigmentation, like a typical look is there. Now remember, it's a long case, short notes, a main question, MCQ, a lot of MCQs will be asked in the varicose, very, very common thing for UGs. All these things, look for DVT, CA, because if it is short note, we should just before the exam read it. Very difficult to recapitulate all those numbers, get confused. And surgical anatomy, like Robinson has already he has covered well. It's very, very important to have a very clear, right? It's very, very complex anatomy. It's a rather more physiological, complex phenomenon, unlike arterial systems, a very clear cut. That's why he said capacity vessel dilate. So many networks are there. So that point also you should have a very clear idea about this. Most of the things, of course, it is there in my book. Next slide. Next slide, Shreya. Okay, this is sorry, Robin. I'll just highlight this is my book, and it's all if you go through, they will know that my website. Please, whoever viewers, I request them to
Yes, sir.
subscribe my book and my website, and of course it's free. And any sessions anytime, please join us sessions. It will be encouraging for of course, and they will learn. Rather, they will learn all these clinical methods in surgery. Next slide, Shreya. So this is the QR code for the next slide, Shreya. Thank you very much, sir. Manohar, sir, give some final.
Thank you, Dr. Ram.
Sir, thank you very much for joining, sir.
Please.
Really,
Yes, sir.
I sent, he said he'll join, then I sent the thing. So very much thankful. Robin, anything to add on to that? She had done excellent actually.
Yes, sir.
I
Dr.
think,
Robin.
sir?
Dr. Robin, sir.
Yes, sir. Namaskar, sir. Hope to see you in Puducherry.
Sir, Robin, have you seen, sir?
I have not been to Pondicherry for exam, sir. The only state I have not gone.
I will call you.
Yes, sir.
I've been
It will be an honor, sir.
Nilanjana Kalaki, Mole, you did very well.
Yes, sir.
Done excellent. So it is very good actually, and it's a long case. Lot of MCQ will be asked, and short notes will be asked. Clinical method will be discussed properly. Whatever we have discussed. Robin, very nice. You have discussed very well, excellently. You have discussed. I think viewers, students mainly probably. That's what we finally want by this channel. Students should learn. Students should get benefited from our discussion and interactions. She has answered very well also, Robin. Good.
Yes,
She
sir.
has a good presence of mind, presence answer. Definitely, big applause for her.
Yes, sir.
Definitely.
Yes.
So,
Thank you very much, sir. I am your student only. I am your chela only, so I cannot change.
nothing. You discussed
I
very
am
well.
only here because of you.
Sir has joined us. It was a moral support to me actually, and when he is there only, we'll get
No,
energy.
yes, sir. I think when you go to US, I think Manohar sir and I will be in touch. So we can. I think our students are very interested. They're going preparing for exam. So they are a very good batch. They are very interested. I think most of the students outside also want to. There are a lot of questions being asked from YouTube channel.
Just go through
I
the
think they
questions.
want us to. Yes, sir. They want us to fuel it apparently.
Shreya, we'll just go through the chat box. How to go through the chat box? I don't know, Shreya.
Nilanjana,
Yes,
politade,
sir.
politade.
Thank you, sir.
Kalaki.
Chat box. This is the chat box, huh? We'll
Hello?
just Shreya, how to go through the chat box. There's so many chat box, so many things are
Yes,
there.
sir. Mission Perfection asked, in patients with chronic venous insufficiency, what are the long-term risks if varicose veins are left untreated? Can this lead to serious cardiovascular complications?
Huh?
Patients with chronic CVA, what are the long-term risks if varicose veins are left untreated?
Can you explain why some patients with varicose vein experience skin ulceration? That's already discussed. Why others do not? That is depending on how much pressure it is there. I think. Then mission perfection. How does obesity, sedentary lifestyle influence on the development of varicose veins, and its weight loss alone enough to improve symptoms? Robin, it's a good question. You can take that question.
Sir,
Obesity,
I am not able to see that question. What is the main question? It's about hormones or obesity?
obesity and sedentary life influences the concept of varicose vein. Absolutely right. But very good question is the next question is the weight loss alone. If you control the obesity, whether it will improve the symptoms.
Obesity is one of the most common secondary causes for varicose veins. definitely when you lose the weight, there will be no more pressure that's causing the venous hypertension, and that will reduce the varicose veins.
Will help.
Absolutely no doubt.
Once a varicose vein and complication has occurred, we have to treat it. But recurrence will not occur if you reduce the weight. So
Yes.
that is the thing I think. And what are the latest advances in non-surgical treatment for varicose veins? So that we are, because of the time lag, we are not discussing conservative treatment. Endoscopic endotherapies are there. All laser, RFA. So many things are there. You can always go through the book. It is there in the book.
Shreya, are we supposed to type, or shall we just say the answers audio? Audio?
Yes, sir, audio is fine.
Audio. Okay. So
Yes.
the question asked to sir was, sir has fielded it. The medical treatment, there are few drugs that are
Yeah.
only for trial basis, it has no efficacy. All the micronized flavonoid products that we have, including Ayurvedic products like horseshoe extract, that sort of thing has come out now with mixed up with our calcium doublet, as Nilanjan has mentioned. There's also pentoxifylline, which is usually used for PVOD, but I'm shocked to see that it is also being given for varicose vein.
Yeah, it is now currently it is said that I went to the literature, Robin.
Yes, sir.
It
Yes,
is
sir.
not much useful for the PVD, it is useful for varicose vein. It improves
Yes,
the
sir.
micro. This is what is said. I am also shocked, but they started using for varicose vein now.
For varicose vein, I am not sure how, sir. We haven't started in practice.
Literatures are there.
Yes, sir.
And chronic venous insufficiency, long-term risk of if varicose vein is left untreated, whether it causes serious cardiovascular complex, the pulmonary embolism, DVT occurs. When the morbid disease, it's a very, very morbid disease, and it's a very complex pathophysiological phenomena in the varicose vein, unlike peripheral arterial disease. It's a very straightforward. This is the complex, very morbid disease, very complex. Venous system is a very complex compared to the arterial system. This is what exactly answer. How does
Okay.
hormonal fluctuation during pregnancy contribute to varicose vein? The progesterone already she has discussed. Estrogen progesterone
Yes.
balance is altered. That's the reason. And many people said she did amazing. She did well. So all these chat box is there. And
Okay.
So there's one question. What is the ultimate confirmatory test for DVT? Whichever student has asked this now, ultimate confirmatory test now clinical diagnosis or a clinical test, or is it for investigation? Clinical, we have already mentioned Perthes is the basic, which gives us a clue from the symptoms. Modified Perthes is the confirmatory in clinical, and the best test for confirmatory test for investigation is color duplex. You don't need invasive, non-invasive.
this one, of course. Doppler scan must actually. B mode ultrasound Doppler scan is a must. Color Doppler. Okay, that is the answer. So, Shreya, most of the questions Gopal gave me here, so I could see that. Uh, uh, One more regarding Washner Manover test, we have to remove the tourniquet and see for the veins from below upward. As Das mentioned, remove tourniquet. Can you please clarify? It's a very clear concept. You have to remove tourniquet from below upward. There is no confusion. I thought I referred, I asked to so many people and finalized it as this one. You remove tourniquet, apply tourniquet, elevate the limb, SFJ tourniquet, and multiple tourniquet as that one. Then ask the patient to stand, see any blowout in between, then release the tourniquet from below upward. And if you may have to do it 2 or 3 times, but most of the time it is now actually in the Venus Association already mentioned that Doppler comes under clinical image method. So they say you have to do Doppler as it should come under clinical method. So all these tests, except generally but test, may not much significant. That's what they say. But as far as analysis purpose, students should know all these tests significant. It clarifies your pathophysiology, complex pathophysiology of the venous system. That's why they should know why these tests have come into the picture. And it's the analytical principle they should know. That's the reason why we stick on to these tests, even though Doppler is sufficient to say all these, give all these answers for all these problems. That's what I think. But it's a clinical method is the analytical one. So that is a very, very important. Like Sir Manohar sir will agree. Clinical should be there. It is
Students, the students should understand is the disease to damage the leaking vein. So that is why we do surgery. Second thing, once the venous system is impaired, the venous return is impaired. So indirectly it will affect the cardiac output also. So that is why the long-term complications, apart from the question what they asked.
Yes, sir. Yes, sir.
That's
Sir,
what I mean.
so there's one question. How would you manage a patient with severe varicose veins and CVI where surgery is contraindicated and conservative treatments have failed to improve symptoms?
No, that is valvular reconstruction. That is the wall
Sir,
we
but
have
the
inserted.
surgery is contraindicated. So valvular procedure can be done endoscopically.
Yeah, that's a microvenous
By,
surgery. Definitely
yeah,
will be done.
by clipping and stapling, we can repair. Valvuloplasty can be done. Yes.
To do in such patients. Definitely, that is the answer. But
Yes, sir.
technically demanding needs a very skilled people for that. They
Yes,
people
sir.
are doing it.
Sir, in this particular case where surgery is contraindicated, we can go for minimal access like laser and RFA.
Definitely.
It is possible because it's not surgery actually. We are doing under tumescent anesthesia, and the indications are clear cut. Once we
Laser,
rule out the deep vein thrombosis, it's possible.
laser is very good. I am regularly doing laser.
Yeah,
Uh,
because surgery is
laser
not required there. Yes.
regularly. So definitely it's very good laser. So they have to know a little bit about laser also. I think recent thing. All this
Yes.
is in the book. Let
And
them.
all the students where the conservative treatments have failed. Now Nilanjan has said in the beginning that we have compression stockings. Compression bandage stockings have two classifications. Please note that. One is the British classification, which has class 1, class 2, class 3 based on the millimeter mercury. And you have the European classification, which is class 1, class 2, class 3, class 4.
So you have to remember that. Please go through this. That's important. Very common. Remember, we are not discussing a disease which is
Yes, sir.
not common. It's a very, very common disease. The
Yes.
20% of population is having varicose vein. So day-to-day surgical practice, we get lot of patients. That's the reason why all undergraduates, including postgraduates, should know everything about the varicose vein. You can't miss. So so final conclusion, Robin, we have covered everything. I think students are happy, viewers are
Yes,
happy.
yes, sir.
Maybe a little more dragging somewhere that is needed because we have to express and kill
Yes, sir. Otherwise, they will not because
idea about the topic.
we have completed the whole topic. We have covered everything.
To cover, you have to give a clear idea of topic, and Nilanjan has presented very well. I'm very happy Manoharan sir has joined us,
Yes,
really,
sir.
sir. And I think viewers will ask, we are going for a very regular event of these things eventually, Robin.
Yes,
Uh,
sir. Yes.
so request all students to join and regularly make use of our website
Yes, sir.
for learning purposes. Nothing more. We want students to learn and increase their academic knowledge and clinical knowledge, basically clinical knowledge through this platform. I'll be very happy, of course. All sir, Manohar sir, Robin, everyone, both of us will be
So
really happy. To
we
learn,
are learning,
sir.
we are learning and updating ourselves.
Okay, that's also we also learn. It is not
Yes.
only we are teaching. By this, we by interaction, we also learn. It is not just we are asking questions. We also think. We also learn from everybody. There's many things I learned from Robinson. I have learned from Manohar sir. My students also will learn because surgery is so vast. I can't say I know everything. But it's so vast. We learn from everybody.
Yes.
So I request for next session. We'll announce later and
Yes,
request
sir.
everybody to join and be interactive with us and learn this one from this platform. We'll be very happy. Robin, we'll wind up.
Yes, sir.
Sir,
Yes, sir.
Manohar sir, my conclusion and a vote of thanks. Manohar sir, thank you very much for joining. You're senior most in the team. You're still
Okay. Thank
very
you
energetic.
for
Learned a
inviting
lot
me.
of it. And Robinson, very nice of you for
I to meet Dr.
finding
Robin.
and
Manohan
making
sir,
this discussion
വളരെ നന്ദി sir. We will see in Pondicherry.
and acknowledging my request and undertaking this one for his student and making this session very vibrant. And Nilanjana presented well. Thank you very much. And all viewers, whoever, please put comments, anything, your views can put. We'll learn from you people also. So anything extra you add on to even your session, give comment, put in the comment box. We'll make ourselves rectify and make a thing better way. I'll request every viewers and students specifically to join regular sessions which we conduct in eventually in this platform. So thank you very much, Robin,
Yes,
Nilanjana, sir, and everybody
Yes,
viewers. Thank you very much. Next week we'll join again. Sir, Manohar sir, I'll send the Google next week, next time also. Please join.
sure, sure, sir. Sure, sir. Thank you, sir.
Appreciate and give your opinion. We'll be very happy, sir.
Yes,
Robin,
sir.
please. Thank you. Thank you.
it's
Good
been
day.
an honor, sir. It's been an
Thank you.
honor.
Thank you, everybody. Thank you.
Niranjana.
Thank you.
Thank you, sir.
Nilanjana presented very well. Really appreciable.
Thank you.
Honestly, I'm telling. Okay, very nice. Okay.
Very
Thank
well
you.
done. Very
Thank
well
you.
done.
Good night, sir. Good night. God bless you, sir. Good night.
Thank you.
Thank you, sir.
Yeah. Shreya, do we have any more questions to field? Either we'll put it in the group or something. Nilanjana, പോയി food കഴിച്ചോടോ. It's getting late. Library close here.
Thank you, sir.
Yeah, Nilanjana, അടിപൊളി. വെടിക്കെട്ടായി. Shreya, are there any questions? Adi, any questions?